Going to again hear from Dr. Moore, and this time we're going to be talking about preventing diabetes in the workplace. And as you know, diabetes is a very prevalent condition in our society, and I think I see different numbers, but I just pulled something up and it said that 34 million people, or about 1 in 10 in our country, have diabetes. And about 90 to 95% of them have type 2 diabetes. And that translates to, I've seen figures from $20 billion to $30 billion annually in terms of workforce or workplace dollars. And that's due to missed days of work, absenteeism, obviously, lack of productivity, people not being able to work. So it really is a huge cost. And one of the things that we work on the grant that I mentioned earlier, the 2 CDC grants we have, is on diabetes prevention. We were able, through that grant, to help support a pilot project with the city of Wichita on a diabetes prevention program. And it was the first year that we did that. I would tell you that we do have an opportunity again this year if anyone's interested in trying to pilot a diabetes prevention program. But we were able to work with the city of Wichita. And so in addition to Dr. Moore presenting, we're going to have Valerie Sokol, who is a senior human resources specialist, benefits manager at the city of Wichita. And Valerie is also a member of our advisory council, and Valerie's been a very involved and supportive member of the Kansas Business Group on Health with the city of Wichita. So we appreciate you being with us today, Valerie. And again, Dr. Moore, I am going to go ahead and turn it over to you.
Okay, thank you, Shelley. So as Shelley said, we are not completely innocent in our presentation of this, because this is part of CDC grant funding that we work with to try to encourage employers to cover the diabetes program as a covered benefit. To tiptoe into the weeds of diabetes here, I want everyone to imagine this guy. So a 43-year-old guy with a body mass index of 32.5, which puts him into the category 1 obesity. He's worked with his doctor, but over time, his BMI continues to climb, kind of like we heard about from one of our sites just a few minutes ago. And his hemoglobin A1C level, that's a sort of measure of how much sugar is baked into the hemoglobin floating around in your blood, is 6.1% with a fasting blood glucose level of 112. So those are levels that do not qualify him for a diagnosis of diabetes, but put him into a range that we would call pre-diabetic. He does not have normal blood sugar levels, but he's not yet at the point where we would consider him diabetic. But every time that this kind of thing comes up, whether it's at his doctor's office or through any kind of worksite wellness programs, he states a desire that he'd like to lose some weight and be healthier. And so remember, once upon a time, again, tiptoeing into the weeds here a little bit, once upon a time, diabetes was sort of this catastrophic diagnosis where you would end up in the hospital, sometimes in a coma, sometimes with vision loss or terrible infections. And it was really diagnosed by syndrome. Once upon a time, doctors would actually taste the patient's urine to see if it was sweet, and that was the diagnosis. But as labs got better and better, we were able to detect diabetes much earlier on. So over time, the very definition of diabetes has changed such that it's really, we define the disease as the point where your blood sugars are high enough that your vision is really starting to be at risk. And you see a sort of a sharp corner turned in each of the 3 studies on the right side of the page there, that once the blood sugars get to a certain point, the odds of you having damage to your eyes gets very high. And that's always the first complication of diabetes. And so we know now, by following people over time, that once you have a diagnosis of diabetes, your blood sugars have actually been abnormal for a very, very long time, probably 10 to 12 years. And this comes from a big study in the mid-90s called the UK PDS study, the United Kingdom Prospective Diabetes Study. So that hemoglobin A1C level in people that are carrying more weight than they want to and who have slightly abnormal blood sugars already tends to rise by about 0.25% per year. And once it hits 6.5%, we know that the diagnosis of diabetes can be made. So this 10 years or so, 10 to 12 years or so before that diagnosis represents an opportunity to do something about this before the person inevitably progresses to a diagnosis of diabetes. So remember, when we go out and screen people for this, we define pre-diabetes, just in case you're curious, as that hemoglobin A1C level of 5.7 to 6.4%, a fasting blood sugar of 100 to 125, or in the rare patient that gets a glucose tolerance test, a 2-hour glucose tolerance test of 140 to 199. And so we know that with age, the likelihood of this goes up. So at this point, almost half of Americans are either diabetic or pre-diabetic. About 1 in 10 has a diagnosis of diabetes, as Shelley said. More than 3 in 10 have prediabetes if you go out and screen them. And we know that around maybe a quarter of those people that have prediabetes will advance to having diabetes within 5 years or so. The reason that we think this is important to employers is that diabetes is astonishingly expensive. So we talked about earlier that in Kansas, Kansas Medicare expenditures are about $10,000 a year. Private insurance is closer to $5,000 a year. So this is from the Healthcare Cost Institute a few years ago. This is across insurance plans, private insurers, people without diabetes have had an annual cost of their care of about $4,400. The minute they switched over to a diagnosis of diabetes, their per capita costs almost quadrupled to $16,000 a year. And that's not all on you, the employer. Most is, but between 12 and 17% of that comes out of pocket of the patient. So it's devastating financially for the patient and for whoever's paying for their health insurance. And so with all that in mind, with this knowledge that diabetes is expensive and morbid, in 2015, the U.S. Preventive Services Task Force said that we should go out and screen everyone between the ages of 40 and 70 who have a BMI of at least 25 kilograms per square meter. And we should repeat that screening every 3rd year. It can be a fasting blood sugar. It can be a hemoglobin A1C level. It can even be a glucose tolerance test, although, as I said, almost no one does that. But they didn't stop there. They didn't just say to screen people, because as the old saying goes, weighing a pig more often doesn't cause the pig to get fatter, right? You have to do something about it. They recommended that we pair that screening with access to combined diet and physical activity promotion programs. And that's really what we're talking about here in the diabetes prevention program. And the primary thing that the USPSTF hoped to achieve out of this was, 1, deciding who was at higher risk of heart disease, but 2, saving money, because the economic evidence indicates that these programs are cost effective. When the cost of your care goes from $4,000 a year to $16,000 a year, it's not, with a diagnosis of diabetes, it's not hard to imagine that doing something to reduce that risk would be cost effective. And so just to sort of tell everyone what the diabetes prevention program is, it comes from this original study of about 3,200 enrollees that were all 25 years or older, all had a body mass index of at least 24, and all had some measure of abnormal glucose metabolism. They all had slightly high blood sugars, but not yet at the point where they would be considered diabetic. And those people were randomized to 4 groups over the course of about 3 years. One group got intensive lifestyle changes. They aimed for 7% weight reduction, a low-fat diet, and about 150 minutes a week of exercise. One group got metformin, which is an old diabetes medication. One group got troglitazone, which was a diabetes medication that was pretty new at the time, but it got removed from the market for hepatic failure, liver failure, and one person in this study actually died of liver failure, so that group was stopped. And then one group got nothing. They got placebo. They got regular doctor's visits and placebo pills. And with this 1-year intervention, in the form of the diabetes prevention program, what they saw was that around 40% of people who got nothing became diabetic over the course of 4 years. People who got metformin were about 25 to 30% less likely than the placebo group to get diabetes. For every 14th, that NNT is a number needed to treat. So for every 14th person that got metformin, 1 case of diabetes was prevented. But the lifestyle program, the diabetes prevention program, was about twice as effective as metformin, meaning that for every 7th person that went into the diabetes prevention program, a case of diabetes was prevented for an overall risk reduction of 58%. You were 58% less likely than the placebo group to get diabetes if you were in this 1-year lifestyle program aiming for 7% weight loss and 150 minutes a week of physical activity. In addition to better blood sugars, the people in the diabetes prevention program arm of the study saw a 25% reduction in medication use for hypertension and cholesterol, and a 1 to 2% reduction in absenteeism, meaning missed work days and productivity loss. So what the diabetes prevention program is again, a 1-year behavior change program that aims for modest body weight loss along with 150 minutes a week of physical activity. It consists of a 16-week core phase where the patient meets with their health coach weekly, followed by an 8-month phase where the patient meets with a health coach monthly. And as you're going to hear from Valerie, it can be facilitated in person or online. And keep in mind, these are not dietitians facilitating the course. This is not the same as going to a nutritionist or dietitian. These are people that are specifically trained as coaches in this very specific program. And so what does it cost? Well, it is a Medicare covered benefit. So Medicare pays for this if you happen to have Medicare folks working for you. If not, it costs around $400 to $450 in most programs as self-pay, and the virtual programs, depending on some specifics in terms of how well the patient does, cost more like $600 for the year. But you see that with every 7th person going into the program not being diabetic when they otherwise would have, and knowing the cost of caring for a diabetic patient, the program is highly cost effective. And so Matt has put together a list or a map of all the diabetes prevention programs in the state, as you see here, and we'd be happy to share this with anyone who's interested. But in addition, there are virtual programs, as you'll hear about, hear from Valerie. So with that, I think I will turn it over to her. And Matt, should I stop sharing and turn it over to you, or what's the best way?
Yeah, let me get that pulled up here. You can stop sharing and I'll get it pulled up. Okay, Valerie, ready when you are.
Okay. Can you hear me, Matt?
Yes.
Okay, thank you. Well, thank you for letting me share some of our information and experience with the group. So if you go to the next slide, Matt. Okay, so the first thing that we did is we had to review our information. So what is it that the city needed to consider for some condition management program? So we looked at the health of our population, and we used screening information that was collected from our wellness program through biometric screenings. And I know that a lot of the employers here in Wichita and on the phone here, they do the same thing. So we were able to identify target health risks through that aggregate information and claims data. Our biometric screening carrier, so we use Quest Lab, they were able to provide us with some aggregate information as well. So we based a lot of it on that lab testing and biometric screening results. I think we all know that when you look at biometric screening results, or even as an individual, if you're able to shift resources from diagnosis to preventive care, those health problems are caught before they become too serious. So that was definitely something that we took into consideration. So those screenings were able to help identify health risks that employees might not know about. And it lets them take appropriate action, but sometimes they don't know what kind of actions to take. And I know this is a little off topic, but we've had some great testimonials from employees who were able to take advantage of resources because of those biometric screenings. And I just want to share one quick testimonial. Last year, we sponsored and promoted one of Via Christi's mammogram parties. And if you don't know about it, you need to look at it. One of our employees that attended was able to catch early stages of breast cancer. And she wrote a great testimonial, thanked the city of Wichita for providing this resource. And it was a very emotional testimonial, just made it all very real. So again, please make sure that you are doing or allowing employees to participate in those biometric screenings. Okay, so when we looked at our information, we were able to identify some of our high risk areas. And those risk areas included diabetes, hypertension, and BMI. And Dr. Moore talked a lot about regular screenings for individuals to determine appropriate programming as well. Next slide, Matt. So I'm sharing a summary of our data that was collected through biometric screenings. And you can see in this information that 85% of our employee population were at moderate or high risk for BMI. So that's pretty significant. That's our highest risk. And other items that stood out, as you can see on here, were blood pressure, waist circumference, and glucose risk levels. You can see our glucose risk levels. Moderate risk was 26% and high risk was 6%, but I'm gonna dive into that a little bit more. So next slide. Okay, so getting into the details a little bit more, you can see that our results compared to benchmark or the database average really opened our eyes, specifically in the BMI area. So obesity 1, you can see that our group was 25.36. The database average was 19.94. So that caught our eye. And if you scroll down a little bit, you can see obesity 2 and what those measurements are. Our percentage was 12.57. The database average was 9.28. So again, lots of opportunity. Now, unfortunately, our extreme obesity was 11.45 and the database average was 6.62. So these are terrible numbers. And, you know, we have a large percentage of our population that is very physical in their job. So we're not all just, you know, we're not all sitting in an office and doing sedentary work. We have employees that are firefighters, police officers, public works, and their work is very, very physical. And we have a large percentage of those folks that participated in the biometric screening. So they participate in our wellness program. So those numbers are also figured into these percentages. Excuse me, and although we didn't drill down our screening data to specific departments, I would anticipate that departments like firefighters, police, and public works, they didn't measure into those high risk levels in obesity or extreme obesity. But, you know, we do have a number of employees whose jobs are sedentary. They work from their offices without much opportunity for physical activity. And then at the bottom of that slide, you can see what our glucose levels were. So our normal levels are less than the benchmark, so that's bad. Our normal levels are 68.37 versus 73.48. And our impaired, you can see what those numbers are as well, 25.51 compared to the database average of 18.54. And our Our high isn't terrible, but again, we see lots of opportunity for some resources. So next slide. So what we did is we were able to partner with the Kansas Business Group on Health, and we selected a diabetes prevention program carrier because we saw lots of opportunity for diabetes prevention. And what were we looking for? Well, a lot of the things that Dr. Moore went through. We wanted to consider a program that follows the CDC program guidance. So that was important. Dr. Moore talked about, well, there's virtual and there's in-person programs. Well, based on our population, and we do have folks that are 24-hour, we thought that virtual might be the most effective. So we went with a carrier that was able to accommodate that. We wanted an intensive behavioral counseling program. And the one we looked at was a 12-month program. We needed a program that focused on obese and overweight individuals and looked at those the following risk factors that are listed. So prediabetes, diabetes, high LDL, low LDL, hypertension, high triglycerides. The vendor that we selected provided smart technology. So they sent each of our participants a wireless smart scale. And that's a pretty interesting feature because that smart scale automatically uploads their weigh-ins. And so they're able to provide those participants with real information, and those participants can see how their weight changes. Professional health coaches. So these are trained individuals specifically for diabetes prevention. Supportive peer group. So that is a virtual peer group that is there to share ideas, share information, share successes, and cheer on their peers. And it's not a peer group taken from your employer. It's a peer group where they can look at different participants or different employers around the country that have something in common. So the peer group, it's almost kind of like a Facebook feature. So you're able to chat with other participants and engaging lessons. So there are a number of lessons that they ask you to complete over the programming period. I want to, at the end of this, I'll share what our results look like in those areas. So next slide. So from an employer perspective, all of those things sound great, but we had to be thoughtful about, what would that mean to the city of Wichita? Well, if we're going to put in a program, we want to make sure that, first of all, we're able to measure those outcomes. And we liked the carrier that we chose because the payments, or what we paid that carrier, is based on outcomes. So if employees enrolled and they didn't achieve any results, or they didn't complete lessons, or whatever the case was, we didn't pay that carrier. So we were only making payments if the participants were achieving specific results. So I think that is an excellent model, because why do I want to pay for something as an employer if it's, first of all, if people aren't engaged and if it's not working? So that had to do as well with the accelerated ROI. And as an employer, we wanted to make sure that that engagement was there, and also implementation. That was important. We don't have a very large team here in human resources or in benefits. So we wanted to make sure that implementation was very easy from our perspective, but also very detailed, so that participants knew what they were signing up for. And it definitely took our HR team out of the loop. We really didn't have any responsibilities as far as implementing the program, except for getting the carrier the data, and then they reached out, did the communication, did the enrollment, did the assessment to determine who was eligible or who was not eligible. Yep, you can go to the next slide, Matt. So I'm not sure if I'm supposed to share this or not, but the carrier that we went with was Omada, and they were a great partner for us, and met all of those things that I discussed on the last few slides. So next slide, Matt. So just to finish up, wanted to share with you what we found out. We are still in our 12-month period, so I don't have claims data to support the success of the program, but I can tell you that we did have very limited enrollment opportunities, but we enrolled at 100%. So obviously that was pretty easy to meet because of the limitations, but I can tell you that all of those members were fully engaged. So our participants engaged with the program an average of 31.9 times per week. So that means they were either going in and doing their lessons, they were very dedicated in weighing themselves, so with those wireless scales, or they were participating with their focus group or their coaches. So I think our engagement was excellent. And you can see in that graph down at the bottom, what our population was compared to benchmark. So our folks were logging in more than the Omada benchmark. So we were doing great there. Our lesson completion rate was excellent, 84.1% compared to their average of 79%. Our weigh-ins were right on target. Everyone was weighing in and doing what they were needing to do. Their food tracking, food and activity tracking, again, excellent. Our folks were exceeding the benchmark in that area. They were messaging their coaches, so they were taking advantage of that opportunity to talk with a professional and ask for advice or recommendations. Our group posts weren't quite at where they should have been, but all in all, that portion was successful as well. And our average weight loss for our participants was over 5%. So again, another success in that area. So like I mentioned, we're still within our 12-month initial programming. And as soon as we are able to collect all of the information, we're going to work with our healthcare consultants so they can help us take a look at if it really did work and impact the claims cost. So obviously as an employer, not only do I want to know that the people who participate in this program were engaged, but I do want to see if it impacts our claims as well. I think as employers, we're all very mindful of, how can we make an impact in those costs. So all in all, the diabetes prevention program that the city initiated last year, I think was a success. And I've been very pleased with the outcomes that I've seen so far.
Okay, well, that's really interesting, Valerie. I don't know, Dr. Moore, we are running close on our time here, so I didn't know if you had any last comments.
I don't think so. Thanks very much to Valerie for sharing that data with us. It's very encouraging. That's exactly what we want to see as we move into these things. And we would love to work with any other members on doing similar pilots with their population.